This is Chester, and together we're teaching you how to access Portacaths. Right this way. I once saw a patient suffer immeasurably due to a simple Portacath access mistake that could have been avoided. Here's how to prevent it and access Portacaths successfully and safely every single time. The cautionary tale that I'm about to tell you is one I will personally never forget. And it's the perfect jumping off point to not only the steps for successful port access, which I will be demonstrating, but also to understanding our first access-related issue, which is improper Fibrin needle insertion. Now, if you don't want to hear the story about what led to this massive error, then jump to the end where I do the entire procedure from start to finish without interruptions. But I kind of recommend that you listen to the story because it's littered with lots of, I can't believe this nurse did that, teaching moments. Saying. So to give you some context, this female patient receiving home-based antibiotic infusion, and we'll call her Maggie, had a single lumen port in her right chest wall, which had been placed about 6 months prior to this occurrence that I'm going to talk about. She was considered obese and had a lot of subcutaneous tissue in the area, so the port was deep and not easily palpated or visible. And she'd had multiple accesses prior to this by a regular nurse, with a couple of them requiring more than one attempt early on. This infusion, however, was being done by a brand new nurse who had never accessed her port before and was covering for her regular nurse temporarily, and we'll call her Katie. And as I continue, see if you can pick out the areas of concern and what you might have done differently. Anyway, on arrival, Katie immediately got to work washing her hands, setting up her sterile field. She had brief conversation with Maggie and told her that she could remain upright in her chair while she accessed her. So Maggie mentioned that her other nurse usually has her lie down or at least recline a bit, to which Katie replied either way is fine. And when she saw Maggie reaching for her robe, she also told her she didn't need it and she could just pull her shirt down. Now, Maggie made mental note of the differences, but she didn't want to seem difficult and she didn't want to make Katie nervous, so she just kept quiet. She pulled her shirt down as far as she could and decided to ignore this anxious feeling that was starting to build in her. And up until that point, Katie hadn't even looked at the port yet, nor did she ask Maggie anything about it, if there had ever been any issues with it, did they routinely get blood returned from it, etc., etc. So the next thing she knew, Katie was scrubbing her port area with chlorhexidine, all while Maggie held her shirt down, praying she didn't contaminate the area. And as Katie grabbed the Fibrin needle, she felt even more uneasy when she realized that she wasn't asked to wear a mask, nor was she told to even turn her head away during the procedure itself. So for the next several minutes, Katie, holding the needle in one hand, proceeded to fumble around with the other, feeling for the port edges, pushing, prodding, repositioning, grasping, and talking to herself, saying, "This port's really deep. I can't feel it. I might need more light." Eventually, an exasperated Katie stood up and paused, but then went right back to vigorously palpating the area again. And nervously, at that point, Maggie mentioned that sometimes her other nurse put a pillow behind her back, which seemed to help, but Katie ignored her, seemingly uninterested in that suggestion. Grabbing the port firmly, Katie suddenly inserted the needle, and Maggie instantly felt that something was not right. And when she looked down, she noticed that the wings of the Fibrin needle seemed to be sticking up strangely as well. Now, Katie realized this too and pulled the needle back to reposition it. And Maggie then noticed what felt like a grating down the right side of her port wall. And again, told Katie it really hurt, but didn't get much of a reaction other than it would go away in a second. So Katie then proceeded to pull back on the syringe and noted a very small amount of blood return. She flushed with a small amount of saline and then reached for the transparent dressing, which is when Maggie stopped her and told her that she did not feel the needle was incorrectly and asked if she could check it again. To which Katie replied, "Your Fibrin isn't fine. The needle is curved at the bottom, so it's inserted at an angle probably just never noticed before. Maggie again did want to push the issue and assumed that Katie knew what she was doing. Her infusion started, and then over the next hour, Maggie told Katie several times that she felt burning, which was getting worse. So Katie looked around the area, she pressed around the dressing a little bit and told her everything still looked fine. And she probably just tracked some alcohol into the insertion site when she was inserting the needle. At the end, Katie flushed the catheter a final time and reassured Maggie that all was fine and removed the needle. Over the next 24 hours, Maggie developed severe radiating pain, tissue discoloration, and blistering, which led her to be evaluated at her local ER, where she was told that she had an extravasation of vancomycin due to improper Huber insertion. I happened to be this patient's regular nurse, and over the next several weeks, she developed ulceration, tissue necrosis, and had to have multiple debridements and the port removed. Now, there are numerous things that went wrong here. Mechanically, the nurse inserted the Huber needle on an angle and went down the side wall of the port, not through the center of the septum. So let's demonstrate proper insertion. Wash your hands and use clean gloves to palpate the port to get a really good idea of how it's seated. If it's tilted, is it a power port or triangular? Is it a single lumen, a double lumen? Estimate the correct needle length. Looking at it, you'll be able to tell whether it's single versus double, but you want as much intel as possible prior to access. Also, look to identify previous needle entry points and use them as a guide to where you'll insert. However, these can shift depending on how taut the skin is pulled or if the patient's lost or gained any weight. And also, note, if it's a power port, it may have bumps on the surface, but don't get too fixated on these because not all will have them. And sometimes there's just too much subcutaneous tissue to rely on them. I find that these are really only helpful when the patient is very thin and the port is right at the surface. It's more important to get comfortable locating the center of the septum, and then this will feel squishy and bouncy. You'll kind of get used to what that feels like. Also, pay attention to how mobile the port is because it's going to tell you how difficult it will be to stabilize. And then last, visualize the catheter to make sure it all looks normal. All right, so let's set up our sterile field. We would open our kit, and you're going to grab the first mask, put it on yourself, and you're going to grab the second mask and put it on the patient, or you can just put one on the patient prior to this. Then you're going to grab your gloves without touching anything else inside the kit, and you're going to set them aside. And then you're going to grab your drape, and you're going to open that up, being careful not to contaminate it by touching anything else. If it has a shiny side, like this one does, that side goes down on the table next to you. Now, for the saline flush, you need to have one that specifically says sterile and is meant to be used on a sterile field. So you would open the packaging of your sterile saline and drop it into your field, and then do the same with everything else. So you're gonna take your bio patch, drop that in, Huber. Feel like those cooking shows into the bowl, and your needle is capped. Then you're gonna put on your sterile glove. Let's see how this is gonna go being on camera, because anybody and everybody knows that as soon as you go to put on sterile gloves and you have people watching, you're all thumbs, literally all thumbs. So you're going to grab the first glove, you're going to grab the cuff of it only, and slip your hand in. Then with this hand, you can touch anywhere on here right now until your other hand meets the glove. So you're going to slide your fingers under the cuff, thumb off. I see a lot of people will leave their thumb on the cuff and they go to put their hand in it, and you've contaminated. So fingers under the cuff, slide your hand in. And don't be afraid to pull. I would also have my watch off. So at this point, you're going to assemble your Huber needle. So you're going to take your needleless cap and you're going to put it on the end of your Huber extension. And then you're going to prime your Huber. And word of caution, when you prime your Huber, always prime away from your sterile field. And then I leave this all together sitting back in my field. Then you're going to grab your ChloraPrep. You're going to activate it by clicking, and you're going to clean your patient. Vigorously scrub the area for 30 seconds. Remember, dry time is kill time. So just let it be. Let it be. Once that's done, you're going to grab your Huber needle. And what I like to do, I like to loop this up in my hands like this. So this way I'm not dragging it across the patient's chest or potentially getting it hooked on anything as I'm going to access. And you'll see many different methods of stabilizing a port. And there's really no right or wrong way. Some people will grab it with 3 fingers like this. But personally, I like to take my 2 fingers like this and put it on either side of the port. And then what you're going to do, remember, we're going to go straight up and down into the center of the port that we should have already identified, perpendicular. So either side of the port this way, you're going to find the center. The needle is straight up and down to the port. We don't want to have any weird angles. And you're going to go straight down and in. Now, when you're initially entering the skin, before you've actually reached the silicone in the septum, the tissue right above the port will feel kind of loose, and it may even slide a little bit. This is normal. So you're going to push straight down until you feel it hit the back of the septum. Now, when you're entering the port, you're going to feel resistance. It's going to feel tight. It's going to feel like you have to push almost unnaturally hard to get it to go through the silicone. The silicone of the port septum will actually grip the needle. It is supposed to be quite tight, okay? So once your needle is situated, you may already see blood flashback. You may see some entering into the extension tubing. But at this point, you're going to pull back and you should see blood immediately. It should be a vigorous blood return, or you don't want to really have to pull back super hard on that plunger. If you're not getting blood return, then what you can do is you can actually push maybe 2 or 3 milliliters of saline into the port and reattempt. And then if you feel that you need to reposition your needle, what you can do is you're going to stabilize that port really, really well. And you can pull up on the needle very, very gently. So it's not coming out of the skin. You want to guard against the needle coming completely out of the skin. But you can pull up and then reposition the needle, maybe angle it a little bit more so it's in the center, and then try again. And then you would pull back for blood return. So that's the trick there. You can reposition the needle, but if that Huber needle comes out of the skin, game over, you need to start over again. Or if you've done your due diligence, you might have found out that there have been issues with blood return, and then you can ask, if shifting position slightly helps, raising their arms, or coughing. And the patient may also tell you that they haven't gotten blood return recently due to a fibrin sheath at the catheter tip, but it's been evaluated under fluoroscopy or through a venography and documented as okay to use for now. And reading the notes on previous access attempts should also alert you to this. So a fibrin sheath is a collection of clotting substances which gradually latches onto the catheter over time. It can happen within 24 hours of catheter placement, and envelop the entire thing within a week. The longer the catheter is in place, the greater the likelihood that a sheath will form. And what happens is with flushing, it blows up and out of the way, but with aspiration, it slams down over the catheter opening and it prevents any blood return. And this is called the ball valve effect. It tends to be more common with polyurethane catheters. And this is why coughing can sometimes help, because that sudden addition of positive pressure displaces that sheath just enough to get some blood return. Now, most facilities will say to never use a port that does not have blood return, but there are a few exceptions to this. Namely, the physician is aware, it's been evaluated and deemed okay, but we can also administer alteplase here or remove the sheath through a procedure in interventional radiology. So from here, you'd flush the catheter with 10 cc's of saline using the push-pause method, which generates turbulence and clears any residual drug, and then either dress it and hook up your infusion or lock it with 100 units per milliliter of heparin and then deaccess.
Okay, so if your Huber needle has been previously dressed and you need to remove that dressing, that is a clean procedure. So you do not need sterile gloves for that. You just need clean ones. And when you're removing the dressing, you always want to pull down from the top this way rather than up. Because if you do that, the Huber needle can pull up and out along with the dressing, and you'll have an uncontrolled access. So always pull down towards you. So once the dressing's off, to de-access, you need to know what kind of Huber you're using because some of them work differently. With this particular needle, there is a safety feature that you can see this extra set of wings below. So I'm going to hold them down while I pinch the yellow wings up and pull straight up and out. And that will de-access the port and activate that mechanism at the same time so nobody gets stuck. So you'll see that the Huber needle is curved. And what happens sometimes is nurses or doctors, whoever's accessing the port, thinks that they need to also curve the insertion to account for this. But that is not the case. That's called hooking the needle, and that is what leads to issues. That's what led to Maggie's issues. And this is what this looks like. So this is hooking the needle. This is incorrect. If you start back here on an angle and then go in that way, okay? And what Katie did the first time, where Maggie said she felt her going down the side wall of her port, is you can see that the septum should be right about in here. So because she was hooking it, she was probably a little too close to the wall. And if you push in that way, you can actually feel the wall of the port. Let me show you. So this is what this looks like close up. And yes, I do have a sponge there because we lost the piece inside. But what happened the first time is the needle went way far out here on the perimeter of the septum. And what Maggie felt was the needle actually going down the side wall of the port. Okay, so this is where you want to be, right smack in the center or as darn near close to it as you can. And then finally, what led to all of the issues was she completely miscalculated the center of the port and must have started at a pretty extreme angle. And rather than going in the center, she started on the far end and probably hooked it this way. Now, quite honestly, with this type of situation, obviously you run the risk of a lot more than an extravasation or an infiltration. You've got your ribs, you've got the heart, lungs, everything in this area, the pleural cavity, and you run the risk also, if you miss the port, of puncturing that and causing a pneumothorax.
And now for the best part. Here are 6 indispensable port access hacks that I've learned through 30 years of infusion practice. Number 1, in the event you don't get blood return but are looking for some added reassurance that the catheter is where it should be, sometimes the patient will tell you that they can taste the saline when you flush. It's like tasting the rainbow. So recall that the catheter is sitting at the entrance of the right atrium, so the medication will be moved quickly through the system. So this tips me off that it's being systemically circulated. Number 2, if you feel that the port is tipped in the pocket, gently use a finger to push on the opposite side of the port to level it. This assures that your Huber is going straight in and cuts down on sluggish flow rates and the need to reposition it later. Number 3, if your patient has a deep port or an angled chest, put a pillow under their shoulders to raise the port up a bit to the surface and provide added support as you're accessing. Number 4, if you're dealing with a sluggish or slow flow rate, have the patient unclasp their bra. For whatever reason, this works a lot. I've used this a lot. Number 5, if the port will be accessed and deaccessed the same day, using a Huber needle that's a bit longer than you might normally can cut down on the tissue compression and discomfort that your patients might have if that port is resting directly on their skin, especially if they're very thin and they have very little padding in the area. Now, I don't recommend this if it'll remain accessed for several days because you do not want to run the risk of accidental dislodgement or tenting of the dressing, causing it to not be occlusive and then increasing the chance of infection. And then finally, and this might be the most important one of the bunch, take your time, assess the port well, and then commit to the step. Patients easily read us, especially when we're inserting any type of catheter. So your confidence gives them reassurance. Doing your due diligence cuts down on errors and builds your proficiency with any skill over time. So remember, you are in charge. You are leading the troops here, and patients are trusting you during what may be the most challenging time of their lives. Understanding peripheral and central catheters and the major issues to watch out for with them is key to safe practice. So click this next to learn how to recognize some dangerous IV-related complications. In the meantime, stay healthy and lucid.
Can I get this in there? Definitely not the way to access support.